Hello, my name is Ann McCarthy. I am the clinical director and the nurse midwife at the Midwife Center for Birth and Women's Health in Pittsburgh, Pennsylvania. We are a freestanding, independent, nonprofit urban birth center, and I'm really excited to take a little bit of time to tell you about our birth center and also how we integrated behavioral health and community outreach in our birth center. Real quickly, just about the Midwife Center, our mission is to promote wellness by providing exceptional client-centered primary gynecological pregnancy and birthing care in southwestern Pennsylvania's only independent birth center. We have 5 birth centers in Pennsylvania. We are the only one that's in western Pennsylvania. About the Midwife Center, we are the only freestanding licensed birth center in western Pennsylvania. We're staffed by certified nurse midwives. We have nurse practitioners on staff who do the majority of our GYN care. We have excellent nurses, IBCLCs. I'm going to talk to you a little bit today about how we integrated a LCSW, a licensed clinical social worker, into our practice, and other professionals. In Pennsylvania, we are licensed by the Department of Health, and nationally, we are accredited by the Commission for the Accreditation of Birth Centers. We've always wanted to make sure that all people can access care at the Midwife Center. We are able to take almost all private and public insurance plans. And for those who don't have insurance, we work on a sliding scale based on income and family size. What's a birth center? There's a lot of myths out there about birth centers, and I just wanted to talk a little bit about that. We're a home-like facility that exists within a healthcare system with a program of care designed in the wellness model of pregnancy and birth. This would be in opposition to an illness model. Almost 85% of pregnant people could access care through a midwife and through birth centers. Birth centers are guided by principles of prevention, sensitivity, safety, appropriate medical intervention, and cost effectiveness. We really work in evidence-based care. A lot of times when you look at the evidence, we find that in America especially, we're doing too much. We don't need to use intervention on every single pregnant person. And that's really what midwives and birth centers in this integrated model are very good at doing, is figuring out when intervention is needed and when it's not needed. A little bit about our history. We became a birth center in 1982 in Pittsburgh. We had a couple of different facilities when we were owned by hospital systems. In 2000, we were let go from the hospital system that owned us, and a bunch of very motivated clients formed a board to become an independent nonprofit birth center. In 2003, the building on the left in this picture was purchased, and we were able to move in and start doing births and care in that birth center. I joined the practice in 2004. Our birth numbers started to really go up around 2010, and we started the planning phases for expansion. We did a $5 million expansion plan. And not only did we want to increase the size of our building, but we also really wanted to do a very thorough and thoughtful process for increasing our programming and absolutely trying to provide the best care and more holistic care for our clients at the Midwife Center. So our building on the right, our expansion was opened in 2017, and I'd like to show you just a little bit about that. So programming and services. Like I said earlier, we do offer primary gynecological care. We have 2 excellent nurse practitioners, and we really try to help people figure out when they want to have babies, or if they don't want to have babies, we want to be there for them in that way also. We do prenatal care, childbirth, postpartum care. We do birth center and hospital birth options. We do water birth at our birth center. During COVID-19, we have temporarily shut down hospital birth options and are working with midwives and physicians in our partner hospitals to make sure that clients have a safe and easy transition if they need hospital care. You'll see in bold the programs I'm going to briefly touch on today a little bit more, and that is behavioral health and wellness. But beyond that, we do lactation support, prenatal classes. We have scholarships for classes. We really don't want there to be barriers for not only care at the Midwife Center, but education at the Midwife Center. With Women Fridays and Con Mujeres are walk-in programs for GYN care, so that people without insurance who maybe have a hard time making an appointment can just walk in. During COVID, we have done same-day appointments for GYN in order to prevent a big waiting room full of people. The other programs I'd like to talk about are the ones here bolded, the community education and engagement. We also do information and resource counseling, and then provide a lot of educational opportunities for nursing, midwifery, social work, and other students. Here's some pictures of our birth suites. You can see our water birth tub. The upper right-hand corner shows a meal. Our nurses make all of our families a meal after they deliver. You can see that this is really an attempt to be a very home-like environment with many safety features. We are able to handle most emergencies in the birth center, and also are taking only low-risk clients, both for care, prenatal care, and birth in the center, which again, about 85% of people qualify for. Here's our exam rooms where we do prenatal care and also our GYN care. You can see that it's not meant to look like a clinic. We do hour-long appointments, so clients have an hour to talk about their histories, their first appointments with us. We have gowns that they wear, and we do all of our histories with their clothes on. When we get to the exam part, they do wear a gown, and all of us practice trauma-informed care. So unfortunately, so many people have been the victims of violence in their life, and we treat every person, whether or not they have had violence like they have, in order to help establish trust and to be a good partner in their healthcare. Just would like to take a minute to talk about statistics. I think this tweet from the Society of Maternal Fetal Medicine is especially poignant, and it says, if being a Black pregnant woman were an occupation, it would be the 5th deadliest job in the country. For a Black woman, becoming pregnant in the 21st century is more dangerous than being a steel worker or working on a construction site. This is especially applicable because we are the Steel City in Pittsburgh, and also because a very important report was released last year that showed that Black women who have babies in Pittsburgh would have better outcomes in 97% of other cities. So we have a real problem on our hands in the United States, but especially in Pittsburgh. It's really important to look at health disparities and outcomes, and for us, especially looking at outcomes in birth centers. So we participated in the Center for Medicaid and Medicare Innovation study called the Strong Start study. And we were one of the biggest contributors to that study. And these results were released in the last 2 years, you can see. And I wanted to go over just a little bit of the data real briefly on what kind of outcomes do people have in birth centers. So you can see that our AABC Strong Start birth outcomes compared to the United States were much better. Preterm birth was significantly reduced, 4.4% versus 9.85% in the US. And then there's rates for low birth weight and very low birth weight. When we look at primary C-section rates, so that's the first time somebody has a C-section, you can see the Strong Start study of clients who have Medicaid insurance and birth with a birth center practice in the United States had a primary C-section rate of 8.7% compared to 21.8% in the United States. Overall C-section rate, you can see for Strong Start with the birth center study, the rate was about 12.3% compared to 31.9% annually. One important thing to just say here too is that all the clients that were in this study were Medicaid beneficiaries, and each birth was assessed to save the system over $2,000 per delivery. But it's really important to look at how did African American women do in these studies compared to white women. So you can see here in the far left corner, the AABC Strong Start study showed that all races had a preterm birth rate of 4.42%. So although there's still a difference between the orange column, where African American women had a preterm birth rate of 4.97%, it's much reduced disparity compared to all races in the United States and African Americans in the United States. You can see this follows all categories. there's more work for birth centers to be doing, and it's important that we're doing that. But you can also see that people who access care in birth centers have much better outcomes if they're African American than the national rates. Another important statistic to look at was C-sections. So for all races, like we talked about earlier, the average percentage was 12.3%, and then for African Americans, it was 15.1%. So let's talk real briefly about the programs that we created. Like I mentioned before, we did a really thorough process for figuring out how to best reach the most vulnerable people in Pittsburgh, and how to make our care most accessible and most helpful. And after a really thorough process, we found that behavioral health was one of the most important things that we could do to help people in their pregnancy. I think it's pretty important to think about how over the last 30 years, we've had more and more and more technology and intervention in pregnancies in the United States, yet we spend the most amount of money by far of anybody in the world, and we have some of the worst outcomes. And so we found that really looking at social determinants of health and helping people in those regards has really impacted outcomes. So you can see we did establish our behavioral health program in 2017. This is an integrated in-house behavioral health service. So it's really nice because clients can come in for their prenatal visits, and then they can go visit with our behavioral health specialist. And then we have a monthly chart review meeting where our behavioral health specialist meets with all the midwife staff and our medical director, and everybody who accesses behavioral health understands that there's co-care. So we're all working as a team, working together to try to help families to have the best outcome. So you can see the mission was to increase access, reduce stigma. Most specifically, we work in individuals, families, and groups for psychotherapy. We offer assessment, short-term behavioral health interventions. So these are 6 to 8 sessions or so. And if somebody needs longer-term care or they need a higher level of care, our behavioral health therapist works with the community to make sure they're getting access and to make sure that there's a warm handoff and follow-through. Care is accessible through 1 year after birth. And group sessions have been incredibly popular among postpartum clients. We found with the pandemic that this has been incredibly important. We have pivoted to generally a telehealth or a video conferencing, both for groups and individual behavioral health care. And for some people, it's been easier for them to get to care because they don't need to leave their home, and they're comfortable and sometimes feel more safe in their home. But we do worry about the impact of not seeing clients face to face, especially for groups. And these are things we won't know for quite a while yet. The other program I wanted to touch on was community engagement and outreach. Like I said earlier in this presentation, in Pittsburgh, we have incredible health disparities for people of color. And what we found when we went through our process of how we could get a better reach into communities that could access care with us, we found that we really needed to earn the trust of the community and work on ourselves to make sure that we are doing the best we possibly can. So we've done at least twice yearly diversity and inclusion training in our staff. And we made it a really important, diversity and inclusion, a really important part of planning for the future as well. And so we were, through a grant, able to hire a community outreach and engagement coordinator. And she works really hard to partner with other organizations that align with our mission. Some of these examples are the Food Bank, Healthy Start, thrift stores, diaper banks. And she really works with the schools too, getting our midwives and our nurses in and talking to people about not only accessing midwifery care for themselves, but also considering midwifery, nursing, lactation consultants, doulas, all of that, and really working in the community to help them to consider this as a career. We're only going to improve outcomes by diversifying the workforce and really earning the trust. When we have had our community engagement coordinator on staff, we've been much more successful at looking at the diversity breakdown of our clients and really having more of an impact. So I very much appreciate you listening today to my presentation on what we're doing in Pittsburgh. I hope this is taken to a grander scale and that every community not only has a freestanding birth center, but a lot of midwives for clients to access. Thank you.